Welcome to a presentation on Dorothea Orum's self-care model, presented by Matt, Tanea, Michael, and McLean. In this video, we will provide a discussion on Dorothea Orum, why nursing theories are important, an overview of the self-care model, including the main concepts, linkages, and applicability in nursing practice. The video will conclude with a case study illustrating the clinical utility of Orum's self-care model in action. Dorothea Orum was born in Baltimore, Maryland in 1914. She was raised by her mother, who took care of her and her older sister. She attended Seton High School in Baltimore and graduated in 1931. She then went on to earn her diploma from the Providence Hospital School of Nursing in Washington, D.C. in 1934. Following this, Orum attended the Catholic University of America and earned her Bachelor of Science in Nursing Education in 1939, and eventually a Master's of Science in Nursing Education in 1945. After receiving advanced degrees, Orum focused primarily on teaching, research, and administration. She worked in several different positions throughout her career, including work as a staff nurse, private duty nurse, administrator, nursing faculty member, and as a consultant. She was the director of the Providence Hospital School of Nursing in Detroit, Michigan from 1945 to 1948, where she was also a professor. From 1965 to 1966, she served as the Dean of the School of Nursing. During her career, she worked on her concept of self-care and in 1980 published her first edition of Nursing Concepts of Practice, which highlighted her self-care model. Nursing theories, as with theories from other fields such as medicine, philosophy, and psychology, are at the heart of practice, planning, and research. Theories are integral to nursing practice and influence how the nurse collects and analyzes information, as well as how that information is interpreted, understood, and used. Nursing theories serve as a cornerstone for understanding and guiding nursing practice in areas such as professional practice, teaching, designing learning activities and curricula, as well as research. Theories provide a basis for the creation of research questions and assist researchers in focusing their observations and data collection methods. As with Orum's self-care theory, theories attempt to describe and explain various phenomena. In Orum's self-care model, she describes the when and how a nurse can assist a client in maintaining or achieving an adequate level of self-care. She also explains the three combined concepts of self-care, self-care deficit, and nursing systems, which makes up the general self-care model. As a nurse, it is important to remember that the perceived clinical utility and usefulness of a particular theory is related to personal and professional relevance at any given point in time. Orum's self-care model was described by Mealis in 1991 and 1997 as one of the human needs theories of nursing. Orum's self-care model can also be described as a grand theory, as it represents the broad concepts of self-care, self-care deficits, and nursing systems within nursing. Orum's self-care model emphasizes the individual's need for self-care, which the nurse can assist the client in achieving through various actions to promote health and well-being. The extent of nursing care provided depends on the degree to which the client is able or unable to meet their own self-care needs. Therefore, the role and function of the nurse is defined in terms of the client needs. In Orum's theory of self-care, she puts forward the concept of professional care. When the nurse identifies that a self-care deficit exists, where the client is incapable of providing continuously effective self-care, the nurse must act using one or more of the 5 methods of helping to assist the client in achieving or maintaining self-care. As such, the nurse is considered an agent of change.
Orum's self-care model is composed of the 3 interrelated concepts: self-care, self-care deficit, and nursing systems. Existing within this system are conditioning factors, self-care agency, and self-care demands. Self-care involves a few other concepts that Orum included within her self-care model. These include nurse agency, the ability to nurse; self-care agency, the ability for one to engage in self-care; basic conditioning factors, social determinants of health and health history; and therapeutic self-care demand, what is needed to sustain basic self-care needs. Self-care deficits are unique to the individual and the health challenges they are experiencing. For example, someone who has experienced a stroke may experience cognitive impairment, perceptual impairment, and neuromuscular impairment. Those with severe deficits may not be able to feed themselves, perform self-care or personal hygiene, or be able to perform everyday tasks that require adequate physical mobility, such as making food, going to the bathroom, etc. Whenever one is unable to meet the requisites of self-care, a deficit occurs. This gives nurses the unique ability to assess, plan, and implement strategies that aim to support individuals who are experiencing self-care deficits. Orum's 5 methods provides nurses with a blueprint on how to implement such strategies.
Another concept of Orum's theory are nursing systems, which describe the level of intervention needed to help meet the individual self-care needs of each patient. Orum describes 3 different kinds of nursing systems: a wholly compensatory system, a partially compensatory system, and a supportive educative system. A wholly compensatory system is when a patient is restricted and cannot perform self-care. The nurse will help the patient perform self-care while still allowing the patient to perform as much of the action as possible and being supportive as they perform the action. A partial compensatory system is when a patient and nurse work together to meet their self-care requirements, where the patient performs what they can and the nurse helps complete other self-care tasks that the patient cannot perform or require assistance performing. A supportive educative system is when the nurse and patient work together and the patient can perform all self-care tasks while the nurse regulates their exercise and development of self-care agency.
So now that we have discussed the predominant components and concepts that make up Orum's model of self-care, it is important to rationalize how this may fit with everyday nursing care. Overall, the model proposed is logical in nature and actually relatively simple to follow, allowing it to be incorporated into multiple areas of practice. Combining the main concepts results in a practical 3-step nursing process that is somewhat comparable to the popular nursing process of assessment, diagnosis, implementation, and evaluation, however with a major shift of focus on the client's ability to self-care. So for example, in applying this model, the first step would involve the determination of why nursing care is needed by gathering and analyzing information on various self-care requisites. So this would include data pertaining to the client's health status and their own perspective of it, the client's goals based on their life and health context, their requirements for self-care, and finally their capacity to perform self-care. So with the client's needs identified, the next step would involve selecting the required nursing systems to plan for the appropriate delivery of care. So as touched upon on the previous slide, the nurse can design a system that is wholly compensatory, partly compensatory, or based on supportive education. This helps bring out a way to organize the components of a client's therapeutic self-care demands and set up an appropriate combination of ways that helping will be effective and efficient in overcoming or compensating for specific self-care deficits. With care initiated, the last step involves managing and evaluating the chosen nursing systems in relation to the set out mutual goals. In this process, the nurse assists the clients or family in self-care matters to achieve identified health results while collecting evidence needed for the evaluation of their effectiveness. We can better demonstrate the model's applicability by putting it into action on the following case study. So let's consider John, a 58-year-old male client who lives alone in an apartment in Vancouver. He has been retired for 3 years, was never married, and has no children. When John was 48, he was diagnosed with type 2 diabetes, a chronic disease which runs in his family. Over the past few years, John has been having a difficult time managing his condition. He reported to the previous nurse that he had been feeling unmotivated, depressed, and reported a decreased sense of well-being. Due to these feelings, John has not been able to manage his diabetes effectively. Sarah, John's new nurse, performed her initial assessment and identified that John's blood glucose is 7.8 prior to his first meal. When asked about his insulin, John stated, "I haven't been taking my insulin, it feels like too much work. I'm tired." When asked about his weight and physical activity, John reported that he had not been exercised and has gained about 4 pounds in the past 2 weeks. So as nurse Sarah understands that self-care is crucial for the control of diabetes and includes self-monitoring of blood glucose, diet, setting insulin dosage, and doing regular physical activity. So for John, the first step would really be to dig deep into his own perspectives of dealing with his diabetes, including what is he aware of in regards to his conditions, the strategies he is currently using to perform self-care, what his goals are in regards to managing his condition, and insights or assessment into any issues that could be contributing to his capacity to perform self-care. So for instance, his cognitive or emotional state, like his reported symptoms of depression. In other words, the determination of his adequacy of self-care based on his care demands. In addition to determining areas of care that John is potentially well managing, with the analysis of information gained from John, Sarah would then be able to determine individual nursing diagnoses such as a deficit in the awareness of his condition or self-deficit in planning for his needs, and then determine the most appropriate methods of helping based on designing a nursing system. So for John specifically, the supportive education system would likely be appropriate in providing guidance in the development of self-care agency and eventual goals of accomplishing his self-management of his diabetic condition. More specific interventions for supporting John's self-care could include ensuring that he is referred to a diabetes clinic where in-depth education and strategies for managing his condition could be included, providing information on social support groups like peer-to-peer diabetes groups, and if co-determined with John, referral to an adult mental health to assess and support any underlying mental health issues John may be experiencing. And of course, future check-ins to help evaluate if goals of self-care are being met or if changes in the level of support or nursing systems should be considered. This brings us to the end of our presentation. We hope that we were able to provide insight to Orum's theories and how our model can provide a unique perspective in providing utility in professional nursing practice.